Well, good morning, all. I am Dr. Laura Lacher, and welcome to Medical Grand Rounds. Very excited for a special session today, but before we get into that, I'll begin with just a couple reminders and logistics. Please be sure to join us for next week's talk. We will be hearing the Oregon Hepatitis C Elimination and the Oregon Experience, Harnessing Innovation and Interconnectedness to Achieve Elimination. And that will be given by Dr. Andrew Shaman. Just a reminder that Grand Rounds is now a joint collaboration between Providence St. Vincent and Providence Portland Medical Centers. We are often live in person in the auditorium at St. Vincent on Tuesday mornings at 8 a.m. and sometimes live in person at Providence Portland at noon on Tuesdays. We are always here on the Teams Live platform as we are today. You can earn CME credit by being live in the room, by watching virtual live, or by watching a recording of the session. And just a reminder that that recording is available at the invite for Grand Rounds each week. And now on to introductions. I'm delighted today for today's talk, Transforming Care, Driving High-Value Care in the Post-COVID Era, which will be given by Dr. Susan Huang. We are joined by special guests, Dr. Ben LeBlanc, Chief Executive of PMG Oregon, Pam Bauer, Chief Executive for the High Performing Network, and our session today will be moderated by Dr. Cheyenne Huang, Chief Medical Officer of the High Performing Network. And now I'll hand it off to Dr. LeBlanc for introductions of today's speaker.
Thanks, Laura. Hello, everyone. Good morning. It's my pleasure to introduce Susan to you all today. Susan is our leader who serves as the Chief Executive for the Providence Clinical Network. She's going to tell us a little bit about what that means, but basically encompasses all of Providence's medical groups and ambulatory operations. Susan joined Providence in 2021, and since then, she's used her extensive experience in physician leadership and patient advocacy and value-based care, health plan operations, and strategic growth to move our organization forward. In addition to leading the PCN, Susan's also served as the Chief Medical Officer for the Providence South Division and as the Chief Executive Officer for the California Payer Provider Providence Health Network. Prior to Providence, Dr. Huang led value-based care as a Chief Medical Officer at the Palo Alto Foundation Medical Group within Sutter Health. There she defined the vision, strategy, and tactics for establishing the organization as a leader in high-value care and becoming the provider of choice. As an innovator, Susan helped develop one of the first successful AI models in healthcare at Google. With a background in research, she's a published scientific author in journals such as Nature. Clinically, Susan's a board-certified dermatologist. She studied medicine at Harvard Medical School and completed her residency at Harvard, including the Brigham and Women's Hospital and Mass General Hospital, where she was elected chief resident and completed executive education at the Harvard Business School. So please join me in welcoming Susan for our talk. Thanks, Susan.
Great, thank you, Ben. All right, so today we're going to talk about driving high-value care in the post-COVID era, and we do have a treat for you. We're also, at the end of this talk, going to go over a use case which Dr. Cheyenne Huang will walk us through. So let's go to the next slide. I want to share a little bit about our Providence Clinical Network, which Dr. LeBlanc shared a little bit with you as well before. Let's advance to the next slide. The Providence Clinical Network encompasses 3 different units: the clinical institutes, which are our specialties, the physician enterprise, which is our network of doctors and physicians and providers, and then our ambulatory care network. And some of the opportunities as these 3 different units came together a couple years ago to form the Providence Clinical Network were opportunities to achieve financial sustainability. And this includes through driving value-based care, which really encompasses the need to really have a full continuum view and the integration of multiple assets within our delivery system. We continue to invest in both primary care strategies and specialty care strategies and thinking about how we link those 2 together. Strategy, prioritization, decision-making, and escalation via a single management structure enables us to execute ever more effectively. So that's a very broad, high-level overview of what the Providence Clinical Network, or PCN, is. Let's go to the next slide. So when you think about the PCN and this network throughout 7 states, there are a few statistics I want to hone in on. First, our fully employed or affiliated doctors encompass more than 10,000. That includes physicians and APCs, over 30,000 caregivers, and in terms of clinics, over 1,000 primary care and specialty clinics. We have a number of dedicated 65 plus clinics focusing on the senior population as well. The number of patients that access us for care and encounters every year is 9.5 million. That's a very hefty number. So those are people who interface with our network, and we have that opportunity to provide that excellent, high quality, high touch and personal care. We also have retail clinics, urgent care clinics, ambulatory surgery centers, and also ambulatory imaging centers. Let's go to the next slide. One thing that we're working on as we look forward to 2025 is structuring our work into different pillars. And this is in draft form, so feel free to send any thoughts about it. But I want to run through some of these pillars. So one is around people and culture. And really that goal is to think about our workforce and the culture and the mission centricity that we have within Providence, which is unique to us, I think, compared to many other organizations. And to really build that out because our people are the heart of our organization. Another one, which is very relevant to this talk, is the pillar around high value care and clinical excellence. And many of you out there take care of patients every single day and know this is a core focus of why you do what you do. And as we think about the quadruple aim of balancing the clinical outcomes, the experience that patients have, our workforce's experience, and then the financial sustainability and cost of care, this is really critical as we think about the future sustainability of healthcare. We also call out patient experience and engagements as we think about our promise of Know Me, Care for Me, Ease My Way. This is bringing that promise to life for our patients and also to our communities. We think about patient empowerment and also how that really is critical and feeds into the valuable care that we can deliver. Core to patient experience and engagement is also how we access care and our patients' ability to access, and not just through one modality, but through multiple different ways of accessing our care. Financial sustainability is called out and also very important when we think about delivering on value-based care. We know that healthcare systems are really under pressure. The government as well has kind of a budget neutrality approach to how it thinks about healthcare, and yet those healthcare costs continue to rise. So really, what is the good for healthcare more generally in the United States? And then how does that play in for us as a healthcare system that has to work with different partners, payers, employers, and then also our patients and communities? One of the focuses as we look to the future is both strengthening our core, but then also transforming for our future, but not as mutually exclusive things, but the transformation really should enable us to do our core work better. So as we think about operational performance and efficiency and the ability to really deliver that care effectively and efficiently, there will be also an element of transformation that is involved here. And then lastly, we added this as we look forward to 2025, the 6th pillar, which is growth and innovation. And there are many technologies that are now available to us, which are not, in the past, were not available. And these could truly be transformational. So do we have that ability to harness the power of innovation? And again, not in a mutually exclusive way with what we do for our core kind of healthcare operations, but really to redesign, rethink what we do, how we do our work, and how we operate. So let's go on to the next slide. So I'm going to talk a little bit about driving high value care. Let's move to the next slide. So why is this important just more globally. So there are a number of macroeconomic shifts that have occurred, and certainly throughout COVID as well. You've probably heard about population shifts, and our population is growing, it's aging, and it's becoming more diverse. And you can see some of the statistics over there. But as this population is growing, we know that the growing population also has increased clinical, medical, and social needs too. And we've seen an acceleration of that complexity of care after COVID. And some of it could have been from kind of deferred procedures, deferred upstream care, but also that's concomitant with the complexities and just the changing demographics of our population. And so what this really means is that how we took care of people in the past might not work, and we have to rethink some of our strategies. And also, as we try to personalize care, the shift of the needs that are showing up in our clinics or in our hospitals, they are becoming different, and that's also going to put pressure on the existing models of care that we have. We also know at the same time that the trends are such that there's going to be really a workforce crisis and not having enough people working in healthcare. And this is really for any segment of healthcare, whether we're talking MAs, LVNs, nurses, physicians, APCs, or others too. So you see some of the statistics here for 2030 outlook. Physicians and nursing certainly, but really all those other segments. And we're also seeing that as we have these different shifts occurring at the same time, it really compounds the issue. When people talk about the administrative burden or the amount of burnout, it's kind of many different streams coming together and causing this. And that will also further our healthcare worker crisis as people are rethinking their work personally, thinking maybe about early retirements or decreasing FTEs or how they spend their time. This can really further challenge really that macroeconomic picture of where we are in healthcare and where we will be. So where does that leave us? And to remain viable and competitive, it really means that we have to rethink the type of care that we provide and think about that care model transformation. You might have heard about team-based care, where we work in teams, have everyone working top of license, different elements of practice transformation, and then thinking about how AI can automate or augment or assist our workforce as well and serve as amplifiers. I think we have to think about the different segments of our workforce differently too. And patched with that is also the segments of our communities and patients that we serve. And then we need to be open to new payment models. And some of this will be around value-based care payments and then also aligned incentives, including internal incentives as well. But all these things really do have to line up. And that's some of the complexity that is needed in driving value-based care. Let's go to the next slide. So we recognize that there are a lot of challenges on the path to succeeding in value-based care as well. And new entrants to this arena really, sometimes struggle with the decision to enter value-based care. And some of that is because of the investment in infrastructure that is needed. And it can take 3 to 5 years before you start bending that curve and seeing some return on your initial investments. So it does take the mettle and the fortitude and the commitment to invest in the infrastructure, in the culture, in the different workflows and all those different pieces so that one can be successful. There are also elements outside of our control, and these are things like regulations at the federal and also state level, programs which are dictated at the federal and state level. There's the market dynamics, and so understanding who are the competitors in the markets, as well as the dynamics with the payers too, and understanding those relationships and then perhaps opportunities for partnerships. For people, it can be, we talked a little bit about incentives. So the way that we're structured today might not be the way that we're structured to do work that makes you so successful in value-based care. There's also a cultural shift, we know, because there's ingrained practices in how we can be successful in one model, let's say fee for service. And sometimes those elements and those practices can be in contradiction with being successful in value-based care as well. Technology, we have a lot of opportunities here, but this is where a lot of investment is needed. So when you think about a technology stack and really what is needed at every step for value-based care, whether it's providing the right insights at the right time or helping you understand your managed care financials, there is a tech stack that is needed, and that does take investment too. And yet there's great opportunities with AI. And then lastly, execution. The speed to execution is what drives your ROI financially, but then also which drives your outcomes that you're looking for clinically and from an experience standpoint too. So developing the right structures and alignment, the operating system and models, and then expertise is really critical to this. Let's go to the next slide. So as I think about Providence and how we've structured our long-term strategy, we talk about strengthening and differentiating our core, being a trusted health navigator, and transforming health through collaboration and innovation. And all these things really would fuel a strategy around value-based care as well. So I don't want you to think that this is just kind of something out of left field. This is actually really core to what Providence is about. Next slide. And that transformation at scale is something that is core to Providence. We've made several investments really in the setting of some really big changes too, right? If you think about the Great Recession, the passing of the Affordable Care Act, COVID, inflationary times, et cetera. We've had that ability to really make those decisions. And when I look at other institutions outside of Providence, sometimes it's only that I say, wow, this is actually pretty impressive what we have committed to. Our Providence Health Plan being started in 1984, so having that foresight for really integrating care and creating that vertical integration. In California, there was the Providence Health Network, which is a plan which I led in the past, but it's tightly tied to Providence and can really drive those results too. The acquisition of the U.S. Family Health Plan in Washington in 2014 as well. And then many other examples here where we've made institutional commitments to really drive that transformation. Let's go to the next slide. So I talked a little bit about value-based care investment, and that sort of thesis and approach continues even through COVID-19 and through the macroeconomic challenges as well. In fact, during COVID-19, you saw that value-based care performance financially did very well, right? Because people did not go in to the hospitals or for care. So people kind of asked, and it brought attention to, well, let me learn a little bit more about value-based care. Maybe that makes sense for diversification of our portfolio. But we've seen this investment continue even after COVID-19 as well. And the key is to really leverage what is differentiating about Providence, which includes significant scale and size and the ability to build that infrastructure in a centralized and coordinated way. And then the ability to link all these different pieces of the asset across the continuum, and also the clinical network as well, because we know that the tip of the spear really is at that point of patient care. And just a few things I want to call out. Across all of Providence, we have over 1.5 million covered lives, over 130 VBC contracts, and shared savings in 2023, over 100 million. I believe this is either the largest shared savings or one of the largest across the United States that has been achieved. And then 4 high-performing networks and clinically integrated networks. And then in one of the programs, the MSSP program, Medicare Shared Savings Program, ACO, with the government, we see that there are wins here as well. And we are managing these patients, even though it's in an open system and these patients can really go anywhere. But we are keeping them healthier and well compared to others. Let's go to the next slide. Realize that the audience, all of you are in Oregon. I wanted to talk a little bit about the California example. This is something that we shared with the rating agencies this past year because they wanted to know about our efforts in diversification and some use cases of success as well. And so we gave them the example of California and in Southern California as well, where the membership has increased really over time. The PMPM margin, even post-COVID, has been positive and is increasing. You can see even between 22 and 23. And then importantly, because you don't want to sacrifice quality care for just financial results, that's really just not aligned with how we would want to run value-based care at Providence. We've also seen an increase in that STAR improvement and also numerous awards for our medical groups and clinical performance on contracts and as rated by others on quality. Let's go to the next slide. So our Providence Promise states, know me, care for me, ease my way. And when we think about that, that tip of the spear and that patient interaction, it does come down to knowing someone, caring for them, and easing their way. And there's many different interpretations that you can draw to value-based care, but just at its core, this is akin to what we try to drive at Providence. So I think our mission is something that does state that we do take care of our communities that we serve and the poor and vulnerable. Something like whole person care is something that resonates with really our mission, vision, values, and promise. Next slide. So that cultural setup is not to be underestimated. I talked to a lot of people from other healthcare institutions, and they often have a hard time making the case for why value-based care makes sense. But our mission formation and our mission that is closely aligned with principles of value-based care. The engagement of our workforce is critical as well. So places where we see that there is success in value-based care across our footprint included are the places where people have that education and knowledge and that empowerment to lead and drive that change too. Thinking about what are the needs of our people and also the workforce, because a lot of this requires transformation and iterative transformation. So it's not a one and done, but really how can you continually transform to meet those changing needs of your population? And then lastly, those systems such as, whether it's team-based care or Prov 65 plus model, where we can really think about the work and how to align incentives as well. Next slide. So aligning structures. So I think about structures, processes, tools, culture. Sometimes thinking about our structures and how we can line that up is helpful as well. And I know Oregon does this well. This is just a graphic that we've used as we've tried to explain to others kind of what that looks like. And it's really bringing together that IDN or that integrated delivery network. And it's for kind of formal opportunities to discuss performance and accountabilities, but also in the partnership and development of relationship and trust. We've seen that it kind of takes both that kind of formal aspect and informal aspect to really drive that performance. Next slide. A little bit about transformation and what we're doing right now. So value-based care is a priority of the Providence Clinical Network. And we recognize this as an opportunity and also as a responsibility for the end that includes our physician and APC network and also encompassing the ambulatory care network as well. we could have that opportunity to think about these lower cost settings and keeping care close to home, but again, navigating between hospitals, ambulatory, and even kind of at-home care as well. Virtual care, so new modalities, whether it's virtual care, remote patient monitoring, or thinking about opportunities of hospital at home, which we do have active in various areas, gives us also that opportunity to think about matching up the modality of care with the care that's needed. So really kind of right care, right place, right time, right physician or right APC or provider. And then team-based care, which we talked a little bit about too. And coming from Google, one of the things that I saw work very, very well was when we could really link all the deep expertise, whether it was from a clinician, if we're working in healthcare, or someone in business or partnerships, engineering, or product management, and really being able to leverage all those different backgrounds. And I do think that we have that ability in Providence, where because of our scale, we really have deep expertise, whether it's in IS, AI, operations, or clinical arenas too. So it's important to really think about bringing those expertise forward so that we can co-design and further these models. Next slide. So technology really does have the opportunity for us to kind of rethink how we do care, and that's going to just be critical based on some of those stats I shared earlier about our workforce. We do need to rethink our workforce and how we do work. We do have core competencies within Providence where we've built out certain things and we can customize it to our needs, whether that's something like a MedPearl, which incorporates over 700 evidence-based care pathways, or something like Providence Chat or Prov Aria, which helps with inbox. And at the same time, we do have enterprise partners which have their own core capabilities. And so whether it's like an Arcadia that works on data analytics and insights for value-based care, or Care Journey, which helps us look at utilization and right utilization, and can provide insights to us, or just kind of non-healthcare companies, but those that are working even more broadly, right? So something like Copilot. We do have those opportunities to bring those into our care, and it is something that we're doing much better than other organizations. In many of the conversations that I've had, they've been pretty impressed by just the commitment to bring some of these tools in. Next slide. And so sometimes people put value-based care and fee-for-service medicine head-to-head against one another. And at our core, we're an open system, right? We're not Kaiser Permanente, where we're closed to membership that is tied to our health plan. So we take patients as they come in to see us. And really, the opportunity is thinking about where that wheel of value-based care and fee-for-service volume actually can create a win-win situation for quality, operational efficiency, financial returns, kind of workforce satisfaction, or growth. So there is that opportunity, knowing that the amount of even kind of assets that we have, or investments, or hospitals, or clinics, et cetera, we can't build our way or even hire our way out of the needs that people have, right? So as we move upstream, take care of people well, the people who need the hospitals at that right time can get that access to care, and we're balancing the supply and demands and really managing our capacity too. So really, I think this is a big goal as we think about the integrated delivery network, where we can achieve balance for all those patients that access us, regardless of what sort of insurance that they're on. Next slide. And let's click through. Stephanie, if you can help me just click through this as well. There is going to be a new wave. Let's do a few more clicks. Yep, there we go. We are sitting, I think, at a time where it's not just AI, but there's also a new wave of diagnostics and therapeutics. And actually, some of this is fueled by AI in terms of understanding what are those new therapies, or how do we diagnose people better. And that really has also, I think, the opportunity for us to drive population health at scale, but in a hyper-personalized way, where if you understand the genomics, the whole person aspects, social determinants of your patients, you can kind of treat them more efficiently, diagnose and treat them more efficiently, and then you could do this at scale as well. Let's click through a few more. And then I think 2 more clicks, if I remember correctly. Perfect. And some of this, will be powered by partnerships with others, maybe startups like Gallery, maybe large enterprise companies like Microsoft. Let's go to the next slide. And so as we look forward and think about these opportunities that bring together of a whole person data hub, where it's that hyper enriched patient data, clinical data, but also non-clinical data together, and then leveraging kind of the capabilities we have with AI and the partnerships, we can really think about what is that vision for population health as it meets personalized medicine too. Next slide. So I believe this is my last slide. It's interesting as I think about Providence, which is over 170 years old, and yet our founding sisters, when they landed on the shores of our West Coast, they brought incredible vision and innovation in a startup mentality. They were the fundraisers of their time, raising money from the coal miners. And I do think that we have this opportunity right now with all the different healthcare shifts to really kind of further that work in this modern era of thinking about, okay, what is that intersection of our mission, our compassion, our excellence, and innovation, and how we can continue to scale that work. And I think value-based care really is that intersection of all those elements. And it's why we often talk about the quadruple aim or quintuple aim when we think about driving value. But really that is the goal. And right now, even with all the headwinds with workforce, with economics that we talked about, the setting is right for us to be having these discussions and to further transform ourselves, whether it's through care models or through these economic models. And Stephanie, let's tab over one more slide. I do think, yep, perfect. So with that, I am very honored to turn this over to Dr. Xiaoyan Huang, and she's going to walk us through the Oregon use case and talk about the high-performing network and clinically integrated network.
Great. Thank you, Susan. Good morning, everyone. And I have my partner in crime, Pam Bauer, on as well. And Pam, you can help me as needed. So we're very grateful to have you, Susan, to give us an overview of the big Providence Clinical Network overview of your vision and our strategy. So what we want to share with the group is our local story about the HPN, which stands for High Performing Network of Oregon. So this is a value-based network of 1,700 clinicians, over 70 practices, about less than half of which are Providence employed providers, and the other are independent groups. Half are primary care and half are specialty. So we're not just Providence employees, and we strive and we succeed in our ability to collaborate, especially between primary care and specialty, acute care, and ambulatory care. Next slide. Just to highlight a couple of our success stories, our network has only been around for 4 years. In the last 2 years, you can see, based on our commercial plans, we have been able to improve all 4 of our quality metrics. And on the Medicare Advantage side, we have been able to improve our STAR measures to 4-star and 5-star over the last 2 years and increase our number of lives covered. Next slide. As a result, last year, our value-based incentives earned 4 out of 5 contracts, including our Intel contract, individual caregiver ACO, as well as Medicare Advantage plans. Specifically, next slide, I want to tell a little bit of a cardiology story, since I am a cardiologist and chief of clinical cardiology in Oregon. So this is about clinical documentation improvement. And I wanted to remind the clinicians about this concept called HCC, hierarchical clinical conditions, which really are CMS designation of a higher risk diagnoses in categories. And each year, at the beginning of the year, CMS wipes all of patients' diagnoses. And throughout the year, as clinicians touch these patients, we document, we make diagnoses, and some of these diagnoses carry more weight, which results in more revenue, more money being transferred from CMS to payers, and then through our HPN network into different practices. So it is critical that we, both as primary care specialists, hospitalists, ED docs, everybody who touch the patient, to appropriately document and address each of these chronic disease or acute conditions. So in cardiology, this is a fairly new concept, meaning that traditionally all this work was done by primary care. And last year, we, after learning from Dr. Lori Gluck and team from primary care, we felt that cardiologists can contribute to this work. So next slide. What does that mean? I'm showing one of my colleagues' clinical documentation from a visit dating back to July of 2022. And you can see on the left side, I show a little bit of assessment of, and plan screenshot, which is very brief, touching upon the conditions that this physician was addressing during this visit. And on the right-hand panel were the charges that he dropped for this visit. And if you look, if you were a coder, you would say that this is not a compliant documentation, meaning that what you dropped in the visit diagnosis did not strictly match the problem that you address in the assessment plan clinically. So with our project of clinical documentation improvement, and coincidentally, Epic put into place a new tool called .diag POC, which means that if you put that smart phrase in your assessment plan, and when you start your visit at the problem list and pick appropriate diagnosis that you want to address during that visit, you can pull those diagnoses directly into the body of your note and document underneath each diagnosis. At the same time, these same diagnoses are automatically dropped into your charge, which really eases our way in terms of skipping a step of having to pick diagnosis into your charge. So conveniently, as the chief of clinical cardiology, I had mid-year reviews with these physicians. And so I reviewed 5 of their charts and gave them specific feedback, helped them change their note template. And next slide, you'll see this is the same patient, same physician's documentation after this new template, and you'll see how organized this new assessment plan is in terms of specific diagnosis, specific status and plan, and how these diagnoses are dropped in his visit diagnosis. So for our value-based incentive project for cardiology, general cardiologists, and heart failure physicians, next slide, we did a Q2 chart review, and I graded each of the physicians, and we set our final target to be a 70% passing grade. And you'll see in Q2 chart review, about half of us didn't quite make it to the 70%. But in Q3, I reviewed 3 of the people who didn't pass in their quote midterm exam. And you can see they have all improved on their scores. The bottom half previously, actually, their average score percent score was 23, and now it's 67. So I'm quite confident in their final chart review in December from their Q4 charts, we will be able to reach 70% of charting accuracy. Next slide. Interestingly, we have our own controlled trial, which means if you look at the physicians that we were focusing on in terms of our education and VBI, you'll see the impact of recapturing old HCC diagnosis year over year. So the orange line is 2024 data versus 2023, and you'll see there was a 25% increase year over year by the end of September. Next slide. More importantly, as specialists, our work is about making new specialty diagnosis, and you'll see that again, year over year, this year we have seen a 17% increase in new HCC diagnoses. So this kind of work translates into significant revenue into our network to allow us to take care of these patients on these value-based contracts. So our comparison group, next slide, next 2 slides show you the other cardiologists and APPs who didn't have the VBI incentive. And this is kind of the halo effect that Susan talks about, where when we do these group teaching in our huddle, even though we're not tying their performance to value-based incentives, their performance did improve. But you'll see that in this control group, our year-over-year improvement was 18% versus 2 slides before it was 25%. And then the next slide, this slide shows that the new capture is 13% versus our intervention group, if you may, of a 17% increase. So let's go to my last slide. The point of all this work, though, is to say that this is not just coding, because this is, because when we define the population risk by making the appropriate diagnosis, and when we clean up problem lists and address each diagnosis during each of our encounter with the patient, we really help define the clinical risk of each patient and collectively as a population. And our point is to have the specialists own the diagnoses in their specialty, so that these diagnoses and the problem list are up to date, making them visible to PCPs, to ED physicians, hospitalists, so that we can all coordinate care around the same diagnoses for these patients. And also the HCC coding ensures that adequate reimbursement is coming to the practice. And overall, this benefits the population management. So this is just one example of what we do in value-based care as part of the high-performing network. We're a small but mighty group of only 7 people. And we meet with our practices every month, both primary care and specialty. We have advisory groups to bring primary care groups together or specialists together to share best practices in terms of. So other examples of what we do include assuring referral appropriateness, sending stable patients back to PCP, improving quality by having both primary care and specialists submit quality data to health plans, as well as improving access to screening tests and directing patient to where access is available and quality is high. So this is very exciting work that is clinically relevant to what we do every day as clinicians. So that is the end of my story. Susan, if you want to get back online. So we actually, even though and Ben, even though I prepared a few questions, I see that we do have some questions from the audience. I think I'm just gonna, I guess, publish them. And although now I don't know where they went. No, I can't see these questions.
Go to the Publish tab.
Oh, go to Publish tab. So are we ready to take on some of these questions? From Anonymous, many thanks for this inspiring overview of Providence commitment to patients and value. This may not be the right venue to ask, but the transition of Providence employees to a non-Providence insurance plan feels incongruent with the excellent results you shared today. As we aim to walk the walk, could you speak to factors that lead to this strategic decision?
Thanks, Dr. Huang, and thank you for that question to who's asking, and I know this is very pertinent to our Oregon market as well. And while I'm not kind of as kind of in the weeds of that specific decision, I think it would be important to kind of bring back the decision making around that and why the switch to a non-PHP provider for wellness and benefits for our own providers. So I think whoever, if you ask that question, feel free to just send me a direct message, and then we can make sure to bring that conversation back to you and then back to your groups and audiences too.
Great. Do you have anything to add, Ben?
That's fine.
Okay.
It's a complex question, and for those in the medical group, we can answer the question. It's kind of a detailed conversation. Just talk to your medical director and leader. We can get that information out.
Great. And then the next question is basically asking about, do we have advocacy for our work, I guess.
And we do have advocacy on different levels. We have federal advocacy, so we have a government affairs team that does meet with different leaders on Capitol Hill and leaders from CMS as well. As you can imagine, advocacy as it relates to value-based care is pretty complex. whether you work through an agency like CMS or whether it's through kind of your state senators or representatives. But we do have advocacy on all those fronts. When the new version of the coding came through, risk adjustment factors, Providence organized a response to that, and then conversation around the impacts of V28. And that entailed efforts from really leaders in population health, value-based care throughout all of our different regions, and also at a system level too.
Great. And then from Mary
And-
Potter. Oh,
Well,
sorry.
Cheyenne, there's a little bit more to say on that. I think the question was around advocacy, as Susan asked, answered, but it's also around what are we doing around the workforce. And so there is a lot of work going on in the workforce that folks may not be aware of. So there's Providence University, which, among other things, has a program to train RNs, so virtual and in-person training to develop more RNs. Within the medical group, we have a medical assistant apprentice program to train non-clinical folks while they're working to become medical assistants. Within the medical group, we have our first crew graduating later this week. And we're also engaged at the state level through the groups like the Oregon Health Leadership Council to advocate at the state level for making Oregon a place where we can train more of our own health staff. So everyone's working on this. It's not any one group's problem to solve, but very much engaged in that work.
Great, thank you. And then from Mary Potter, Dr. Huang, I guess that's for you. Are you familiar with PMG at Home, an Oregon value-based care program? This program provides care for PMGs, permanently or temporarily homebound patients who would not otherwise receive care. Its goal is to keep patients out of the hospital when avoidable and according to their goals of care.
Great, thank you, Mary, and I'd love to learn more. And Ben is probably more familiar with that program. I think part of the importance is to think about moving the care upstream, right? So really, how can we meet patients where they are at? And especially patients who are homebound, as you know, often have a lot of social complexity on top of medical complexity, and so often takes additional thinking and resourcing around the care models. So appreciate all that you're doing to meet those patients where they are. Ben, anything you want to add?
No, I'm just glad Mary brought that program forward. It's a program we're really proud of within the medical group, kind of small but mighty. Not every patient, as we all know, is perfectly served by a visit in the clinic. And so some of our most vulnerable patients, this PMG at Home team is able to support in the home. And they just did a tremendous job. So thanks for bringing it up, Mary.
Great. And then a couple of questions. I'm wondering how specifically Providence is using HCC coding for risk prediction and resource allocation. I'm not quite sure what that question means. Pam, do you want to address that? I mean, I think that the coding, HCC coding, allows for increased reimbursement and gives us.
Yeah, I
Right?
can take that one, Cheyenne,
Yeah.
if you want.
Okay,
Pam, you can
please.
add color commentary if you want. So, you know, HCC coding and risk scoring does not fill me with joy. I doubt it fills anyone on this call with joy. It's not why we went to medical school. The challenge is within this way of doing value-based care, where we're taking financial risks for caring for a population of patients. We all know that the illness burden is not evenly spread among these populations. So you really have to be accurate about how sick your patients are, or we're not going to have enough money to provide them care. So it's sort of a necessary task to make sure we have enough revenue to care for these patients. It's not a perfect system. It's not very easy to predict who's going to need medical care, as we all need. So this HCC coding is not real great at allocating resources down to sort of that patient level. You know, like Dr. Jones has a risk score of this, and so they're going to need more of that. Basically, we just need to provide the right services to the right patients based on clinical need, and then make sure we're documenting the severity of illness so that we get enough revenue as a group to care for that population. I think that's how maybe I'm trying to get at what the questioner is asking there.
I'll just add a little bit to that, and I think, Ben, you answered that fantastically, that the goal of HCC coding, I think a lot of times the conversation is around reimbursement, and while it is linked to reimbursement, I think that really focusing on accurately capturing the patient's health status is really important. So we don't want overcoding, we don't want undercoding, we want the most appropriate capture based on the system of HCC codes that exist. Now, in terms of the granularity of information that is needed to then link up to your next action steps, and maybe that's ambulatory care management, maybe it's leveraging resources of PMG care at home, right? That might actually need additional granularity of information. So there are teams working in the background to understand the severity or the risk status that someone has, and they're probably looking at things beyond HCC codes, and maybe it's patterns of utilization of care in the past. Maybe it's understanding that there's actually a rising risk profile that they're seeing with a patient. All of that can be captured as you think about just treating individual patients, but there are kind of those other metrics and data points which your teams are using to identify those patients earlier and then intervening on.
Yeah. The next question is about HCC, learning about HCC coding. It's important, but it's quite stressful for for providers to learn this on their own time. So, you know, our story in cardiology was a success story where we linked the value-based incentive to this work, and I'm going around Oregon, different groups, both Providence employed and independent groups, to teach different groups how to do this kind of project so that the providers could learn on this, which actually improves the efficiency of their documentation during the visit. You know, I think I'm happy to talk to group leaders in terms of how to set up a project like this. I think the ROI is quite high for this kind of work. So we only have a couple more minutes. Do we have other comments, closing remarks from you, Susan, Ben, Pam?
I think, you know, I'm grateful to be able to share some of what we're doing and the vision around VBC with this group. So thank you for your engagement. Thank you for attending. I think there are some very great questions, very insightful questions here. And, you know, a lot of this is just keeping the conversation going. And that great work is the work that you're doing every day. Thank you.
Thank you. Back to you, Laura.
Great. Thanks all. We are right at the 9 o'clock top of the hour. Many thanks to our special guest today, and particularly Dr. Susan Huang. Please stay tuned for Grand Rounds back live in person next week. Take care.